My name is Lika. I'm interested about on the arrangement of subcontractor during the UCS. So it is stated that capitation is contract with community hospital, public and private hospital, but it is subcontracted to primary care unit. I'm interested how is the arrangement and whether the capitation amount is the same between the private and public hospital. That's the first question. Okay, and the second is about the catastrophic condition. So in Indonesia, it is like the expenditure for catastrophic condition is very high. For example, for hemodialysis and also for valve replacement of the heart. So how did in Thailand central reimbursement or another scheme? Thank you.
The contractor. So our concept is that we have a main contractor and then we have subcontractors. So this we also learned from the Social Security scheme since 1990. We have a main contractor, which is the big hospital. Then to provide network of care. Then many of the main contractors will contract even small clinics, so that they can provide better access. And they will have more workers to choose them. The list size will be bigger, and then they will get a higher income. So it depends on the negotiation between main contractor and subcontractor. And most of the payment will be according to the service. Maybe mostly are the fee for service or the pay per visit to the subcontractor. Because most of the subcontractors are at the primary care level. So that is the situation of the main contractor of the hospital, contract to the small hospital or to the clinic. Now to the UC scheme. The UC scheme, we encourage the main contractor to be smaller and focus on the outpatient service. But we still see the situation that there are many small clinics that is the contract to the in rural areas. In rural area, because we have a hospital, community hospital at the what we call the district level, and we have health promoting hospital or health center which has no medical doctor at the village level or the sub-district level. So the capitation will go to the community hospital, not to the say health center. Then there'll be arrangement between with the community hospital, and mostly they will pay for they will give the medicine and also the capital cost for improvement of the health centers to the health centers, and they also may give per visit to the health center. But if in urban area, if they contract to the private clinics, they also arrange that mostly they pay on the per visit. So this is the payment to the to the subcontractor. But we may see as some case that they may refer to the supra-contractor. We call supra-contractor. That means it's more than their capacity. If like a patient with diabetes and they need to be examined by ophthalmologist for eye examination, then they have to refer up to the supra-contractor, to the specialist. So there are many kinds of experience that we may set that if we send to the specialist, we will pay a fixed amount per visit, or from the subcontractor. For the main contractor, we pay subcontractor. But if there are many cases that have to be referred, then we may have a deduction of capitation payment to the main contractor and pool at the provincial level or pool at the regional level as the referral budget. And then the referral will be paid on the referral deduction. So this is the risk pooling. But for the case as your example, that can be considered as the inpatient care. For the catastrophic inpatient care, like putting a stent, this will be handled by DRG, which is a separate budget. But for hemodialysis, that have because catastrophic, because many visits, then they have a separate budget for the hemodialysis or the CAPD first. So that will be a separate budget. So as you can see in the pie chart, for CKD or for the hemodialysis, there will be additional budget for that, separate budget.
Ada lagi yang mau bertanya? Oh, Bu Lika sudah puas dengan jawaban Prof atau masih ada yang? Oh, baiklah. Ada yang mau bertanya lagi? Dari webinar mungkin ada pertanyaan? Belum ada? Dari webinar belum ada pertanyaan? Iya, silakan Bu.
I just want your confirmation because I'm still a little bit confused that so the payer admin at the UC scheme or SSS scheme pay the hospital, the district hospital as a capitation, as a global budget or a capitation for the citizen who live around the hospital. And then the hospital pay the primary care with fee for service or with capitation is the first question. And the second, who is make like a adjustment calculation? You mentioned that there is 18 band aids, how to spare the classification, the age of the population, and how to make a weight adjustment for the capitation itself. Sorry, the third question. As in the primary care, there is no doctor, so the doctor from hospital like supervise the primary care. Maybe it's different situation in Indonesia because in Indonesia.
Okay. So I may confuse the audience. To put this way, first we have experience of SSS, that the main contractor is a big hospital from 100 beds. So this is provincial hospital or the private hospital, can be a private hospital. So this is too big. We consider this is too big there may not be a very good primary care. Then when we have a UC scheme and we shift the main contractor to the community hospital. But so community hospital is it cover all rural area in Thailand, but not very rural as the village level. At the village level, we have a health center. So health center, usually we not have a medical doctor. So the contractor will be to the community hospital, which had the medical doctor. So in terms of to have good access to care for people in rural area, then the community hospital must have a subcontract to the health center. Then they oversee the health center and they give some budget subsidy to the health center. No matter what medicine or the overtime payment or the construction or the renovation of the facility. So that will be within the capitation budget. As you see from the pie diagram. Maybe go to see the pie diagram again. So if we see the pie diagram again, then the hospital, okay. The community hospital will get mostly of the outpatient part, and also some of the P&P part, and some, if they had innovation on this kind of things, rehabilitation, but they will have a capital part, or capital part which may be around here. So this capital part will be put for renovation of the community hospital or with the subcontractor also. So in order to have a good linkage, then they have to pay handsomely to the subcontractor to encourage networking. So that's the first question. Second or third question?
The application and also to wait.
Okay. The 18H ban is not used in Thailand yet. I think we use less than 10. Not very elaborate. The 18H ban is from the England, but in Thailand we may use the weight, the age, sex adjusted. It's from the previous utilization. So we can calculate this by the historical data of the utilization, total population, P and Q. So by different, like 10 age bands, then how many visits for this group, for children, for under 5, from 5 to 14, and then from working age, young working age, and the elderly. So usually the elderly will get a higher weight. So this is calculated at the NHSO. It may change year by year. It may change.
It's the most challenging part because it will be using the historical utilizations and how to cope with
these challenges? Thank you.
The most challenging is that I think the trend in Thailand is that as you see from the pie diagram, we are far too much in dividing into many small cards, many small envelopes. If we use the health status data, that will be more accurate than having this kind of separation. And it may be like we have strong arguments at the moment on the cataract, which managed by CR, by the central reimbursement, which now take about 10% of the capitation budget at the downstream. The ophthalmologists, doctors, the Royal College of the Ophthalmology, then they argue that the office try to encourage cataract surgery, whereas it may not be appropriate at the moment because the blinding, the cause of blindness in Thailand may shift from cataract to other problem. So this is some of the argument. Then I will put in this way that if we have data on the disease illness and try to manage prospectively or within the cohort, then the health risk or risk adjusted can be put into the formula, and also some of the activities that try to manage, not just to address the prevalence of disease, but the data that we had intervention that match to the prevalence of health condition should be the next challenge. And this also put into the documents in New Zealand in 2015 that they want to address this kind of things. So if you mean the beneficiaries, the population, do they get the same benefit package? So we are now at the moment try to make a systematic definition of the core package, or the core, what are defined as core package, and what defined as the additional package. More or less, if we ask if we ask general public, then they will say that they have different things, different package. If we ask providers or the hospital, they will say in a meeting that they provide the same thing for different groups, but in the end, we had some of the outcome studies saying that the outcome from treatment may not be different, may not be the same. There's still the gap, but this gap may be because of unexplained socio-economic conditions, which we want to address this kind of differences in socio-economic conditions, like social class or the underprivileged area, which we are now researching on this. If we are successful in measuring this, that will be a kind of the weight, like in England that they put a 12% weight on the inequality, health inequality. That will be a big challenge, and we'll need more than 10 years in addressing.